my name is Dr. Simon Low. I'm from Penang in Malaysia. It's great that we can meet up like this. We don't have to be physically there, but we love to be physically there as well. From next year, I hope. With me, my co-chairperson is Dr. Sunao Nakamura, who needs no introduction. He's famous everywhere, and he's especially famous in my part of this world. Okay. Now, Dr. Praveen Chandra from India will be joining us soon. But with us now, in the video, you can see is Dr. Eric Hong from Singapore. Dr. Eric, hands up, please. Can I see him? I can't see his picture. Yeah. And then we have from Korea, Dr. Phil Lee from Asan Medical Center. Hello. Yeah. And we have from Taiwan, the safest country in the world at the moment, Dr. Tsao. Yeah. Okay. So we would love to hear from you, Dr. Kenya, and about your case.
Live tapes presentation. Today's case is 70 years old male. Diagnosis is stable angina caused by LAD CTO. Coronary risk factor is echocardiogram is almost normal contraction. He had no renal dysfunction. This is final angiogram. We can see LAD CTO region, and this is diagonal branches respectively. This is RC angiogram, collateral channel from 4PD to LAD. This is previous CAG performed at 27. We can see the whole image of LAD. Today's target region is middle of LAD, diagonal branch. Please go ahead.
Thank you very much. Anyway, this is LAD CDO. And then main collateral branch is not the PD from the conus branch. So, but the issue of this case is the cusp is very big. That means very difficult to engage the guiding for the right coronary artery. So in this kind of the case, I want to show the chip injection from the conus branch, but engage is very difficult. ちょっと多い。フレーミングしてちょっとちょうだい。So I gave up the chip injection from conus. I started from the integrated approach now. So we can show the bilateral shot today. 違う、上じゃない。上が見えないんだ。So this is the today's shot. So left side in the epicranial, or right side in the just LAO 50 or something.
Yeah.
So you can.
Kenya, sorry, can I just invite the panelists to make a little bit of contribution first? My very simple question is, can I just ask the panelists whether they'll just use antegrade approach, or will they even think of a retrograde approach? Yeah. Dr. Lee, please.
Well, I think the most the advantage of this CTO case is that we have a previous angiogram of the LAD, so that's a very good, very big benefit in almost all the case of CTO. So we know the route, we know the distal target, we know the distal vessel size. So in this kind of case, of course, considering that the CTO is a little bit short, but I don't think that it is.
IBUS
We can say that it is always easy, but at least we have the previous NGO. I will start from the integrate in this kind of case.
Yep. Okay. Dr. Eric Hong, please. Your comment.
前は IBUS してみようか。時間どうせ限られてるし。
Can't hear you.
Can you hear me now?
Yes. Yes, we can hear you now.
Yeah, I agree. I would actually, in this case, I mean, I would actually attempt integrate first, and then if I can't, then I will go to retrograde. But my first choice would still be integrate.
Yeah. And then when you do the integrate, because this is almost like it's a Medina 111 lesion. Yeah, it's a CTO Medina 111. Would you put a wire to the diagonal first as well? Or would you try to wire the LID first?
記録してください。
Dr. Tsao? From
Yes.
Taiwan?
Yeah. I think that for this case, I prefer to go integrate first.
Uh-huh.
Yeah.
Yeah.
And
if you do go integrate, would you wire this diagonal first before you
yeah,
attend the cross?
I wire diagonal because probably I used IVERS to guide the direction of the wire. Yeah.
I see.
The CTO wire.
This is exactly what they're doing now. Yeah.
Yeah.
Okay. Okay, Dr. Kenya.
Yes.
So we all agree that we'll go integrate first.
Hmm.
And then, yeah, we wire this diagonal, go integrate, and maybe like you are doing now, ultrasound guided.
Mm-hmm.
Okay.
Anyway, I put the wire to the big diagonal, and then now checking the IBUS from the diagonal. But
yeah.
So maybe you can see the 6 o'clock some brackets there. This is already main vessel.
Yeah.
So in a contralateral injection, we can see the some small channel from the beginning of the CTO side.
Yeah.
So, but in IBUS, maybe not clear. Maybe here is we can see some stump is there, but this is most distal side of the bifurcation. That this kind of situation in the selection of this small channel is very, very difficult.
Very difficult.
And in the angiogram findings is that you can see some tricky angle. The beginning of the small channel. So anyway, we can try to select this small channel with XTR with Cascade dual DLC, dual lumen caster. So can I have the DLC, please?
Is there a little bit of a stem, like a little bit of the channel that you can see, like after the diagonal?
Yes, but channel is beginning very distal of the bifurcation, right?
Yes.
So that's meaning maybe in the selection is not easy.
Dr. Nakamura, can I just enjoy your comments as well, please?
So he wanna start on IBUS guided. So actually I can see the some stump, but he said that this is a location is not so, so easy. Maybe yes. And also we can see, looks like a stump, like Simon said. Maybe I think he will, show us a very beautiful guide wiring. Just watch him.
Yeah.
Actually,
please discuss about this case.
Not so easy. Because the distal target is not so beautifully good size. Maybe a little bit shrink the small size. So maybe I think not so easy.
But we have the advantage of the previous angiogram as well.
That is not the advantage. Actually, LED mostly just going to the straight. So that was just we confirm we have LED.
Yeah.
Well, I suspect that the starting point of the micro channel is quite tricky. The angle is not favorable, so so it will be quite hard to wire it. At least Dr. Nasu will do, I think. But if it was me, well, we could have a try for some minutes with this tackling with this micro channel, and if it doesn't work, if you have a good interventional retrograde channel, then the retrograde will work quite easily. So that's one option for a quick turnover.
Yeah. Dr. Kenyan, can I just ask you what wire you're using now for the LED?
I'm using the XTR.
Uh-huh. Oh, it looks good. Uh-huh. And is an XTR inside a Corsair micro catheter?
This is a DLC Sasuke.
Sasuke, yeah. Looks good.
You have some progress, right?
Yes, but I have some resistance here.
Okay.
I think this is the LED direction. これ LO の60にしてください。スパイダーもいらない。So actually, in CT findings, CTO itself is not so hard. And also the real occlusion length may be 5 or 6 millimeters, I guess. So ideally, I want to get the small diagonal inside in the CTO side, and then try to check the IBUS or something after small balloon dilatation or the Corsair passing. But now, yes, now we can get the small branch. Maybe this is diagonal.
Diagonal branch.
Would you do a retrograde injection now and see where we are?
Yes, maybe we don't need to do retrograde injection. Antegrade injection is better. So after removing the DLC, I will check the angio.
Yeah. You're making it look too easy, we have 1 hour.
1 hour is too short for the CTO intervention, right?
Do we have another case? Stand by.
よいしょ。だから次はコルセアを用意して。コルセアね。
When you take your Sasuke out, do you use an extension wire?
No, we can use the trapping balloon.
Oh, trapping balloon. Okay. Okay.
So Dr. Nasu, can I have a question?
Yes.
So you for this calculation, you prefer to use a double lumen caster instead of micro caster, right?
Yes, usually, of course, you can study. 俺に話しかけるの、日本語で。Of course, we can use microcaster instead of the DLC now. But from this kind of the case, we need to support power for the integrated wire. So that if we use the Corsair instead of the DLC in this kind of the case, selection is very difficult because it's stabilization of the system is very difficult.
Yes.
And also the this proximal side of the lumen LED is a very big, right? So from the big space to the selected the small space usually very difficult.
Yes. Yes.
So in addition, this case has a very tricky angle at the beginning of the channel. So maybe the microcaster didn't work well, I guess.
Microcast cannot provide a steady support in this kind of region.
Yes. So the DLC is better to stabilized.
Mhm.
Is the XT wire in a small diagonal branch right now?
Yes, sure.
Okay.
これ捨てて、でもう一個出して。デフレした？ So now I want to try to cross the Colosseo and then change to the wire to the regular wire, and then check the angiogram. Yeah, Hyung blue がいい。
Looks quite easy to cross.
ほら、ちょっとどんどんちょっと投資保存してくれ、お願いやから。いらん。いいよ。
So are you planning to use a third wire to cross into the distal LED now?
Yeah, before then I want to check the angio.
Mm-hmm.
待って。ちょっとちょうだい。いい？ OK。はい、じゃあチェックするよ。Also, we can see some small stump. Can you see?
Yeah, starting from the distal diagonal, right?
Yes.
Yes.
Yeah.
So maybe we can check the IBUS the same way. If possible, IBUS can be passed. We can see the LED.
Yeah.
So this IBUS is from thermal double R. So now, so far this caster can be used only in Japan, but maybe in future you can use maybe. So, で上には今のを出してこっちは映らへんねんけど下をちゃんと意識してあげないと下全然見えないから会場の人。あ、一歩。はい。IBUS can be crossed, so can you see IBUS? Yes, IBUS is in the second diagonal. So from the 1 o'clock, you can see the LED itself. But some fibrous plug is you can see density a little bit higher compared with the proximal side. Maybe, but almost the same. So also we can see the small channels. So maybe we can study from the XTL with the DLC. Is okay?
Yep.
Yeah, I agree. And geographically, maybe the small channel has a competition from the retrograde.
I think so too.
Yeah. If it's lucky, we can pass it very easily.
So I hope so. もう一本いるよ。新しい XTR 元の出さないともう壊れてるでしょ。 XTR ください。あ、ワイヤーもっといっぱいいろんなものいっぱい持ってきておいで。ACT のチェックなんか彼に任せて、先生はここに行ってくれない。OK。So, so now is the XTR is coming. So I have no resistance.
Yeah.
XTR is advanced gradually. So now it's time to check the contralateral injection. ストアしたストアしたいいいいかいじゃあいくよ。うん、almost だよ。多分、通ってんじゃねえかと思うけどね。
No. The LAO view looks like it's good.
But I have some resistance around here.
On the AB cranial. One further.
Okay.
There we go. Yeah.
もう一回チェックして。もう一回チェックして。どうぞ。
So, well, as you're taking out the double lumen catheter,
Yes.
I just asked the panelists now, what is the next step now? Would they use a single stent strategy, or would one consider, because that diagonal, first diagonal is actually quite a sizable diagonal, would you consider stenting a diagonal and then a two-stent strategy, or would you use a single stent strategy? Dr. Xiao from Taiwan, would you use a single stent?
Yeah, I still prefer single stent. So after the recanalization of LAD, and maybe after stenting, and see how the diagonals are. If the flow of diagonals are not good and the size is reasonable, then probably I use two stent or use DCB.
I see.
Yeah.
And you do a kissing balloon then?
Depends. Yeah, when probably if the ostim is severely compromised, maybe use a kissing stent, like kissing balloon, then DCB or probably second stent.
Yeah, I see. Dr. Hong?
シオンちょうだい。
Would you use a two-stent?
3本シオンブルーだな。分かれへん。本当はシオンブルーの方がいいんだけど。
Can you hear me?
Yes.
Yes, I think my preference is still towards a single stent strategy with and the diagonals being quite acute. I think depending on the size, I may just use a small balloon to just inflate, and then with the idea of using a drug-eluting balloon for the diagonals if necessary, and hopefully not to do with a kissing balloon.
Okay. Dr. Lee, would you do the diagonal dilatation first and then perhaps consider doing a DCB first into the diagonal before you stent the LAD?
2ミリの20出して。
Well, my practice in this kind of lesion, considering the baseline angiographic morphology regarding the angle of the diagonal and the disease at the ostium, I would not do any pre-dilation of the diagonal ostium. Just want to, maybe I would just do the crossover stent first and then look at the diagonal. I think the diagonal will not be, jailed after the crossover stenting, because I see that the morphology is quite good for a single stenting.
I see.
ちょっとパンテのフラーも
Dr. Nakamura?
もうちょっと
Dr. Nakamura, would you
どうやって見せるか
would you also use a single stent
違
strategy
う
for
ね。
this?
レビュー。
Maybe I think my idea is also the same, the single stenting prefer, but actually depend on the size of the vessel after the ballooning of the LED. And actually, we should not forget that this diagonal is a beginner.
Yeah.
And most reliable one in this anterior territory. So maybe I think at least this big diagonal. We should
The previous angiogram showed this diagonal to be quite a sizable diagonal.
But of course, I don't want to implant a stent in a diagonal.
So we can ask Dr. Nasu's strategy.
Yep.
Are you talking about the first diagonal or second diagonal?
The first diagonal.
Yes, of course. First diagonal is very big, so we need to keep the balloon or KBT or something before stenting, if possible. And also nowadays maybe ちょっと上からの画像を見せてくれ。Yeah, I want to balloon protection for when we stand in the LED. ちょっとダイアゴナルの奥が見たいんだよね。ワイヤーが傷んでるから。
So Dr. Nasu, you're going to balloon the LAD first?
Yes, of course. From now on, I will use the 2O balloon anyway, and then check the IBAS and escalated the balloon size or something. 2の20だって言ったよね。絶対あるよ。2の20のバルーンあるでしょ、どっかに。あ、そっか。バルーンってないの
I think the finding of the IVUS would be quite important because the LAD distal to the first and second diagonal was quite big at the baseline. So maybe more than 3.0 or almost 3.5. So the current situation at the distal LAD may be a negative modeling or maybe a combined disease. So differentiating that finding with the IVUS would be important to make the stenting strategy and stenting location.
Yeah, absolutely. Yeah, I think the IVUS would also tell us whether the ostium of the diagonal is calcified or not.
Relationship? はい、どうぞ。15。15? Okay, anyway, we can dilate the LED. So we can check the IVUS now. フラッシュされてる？外側拭いてないよ。 アイバスの外側拭いてください。アイバスの。うん、ちゃんと保持するならちゃんと保持して。よいしょ。Okay. So as Dr. Lee said, distal LED vessel, the blackless but the shrinking. You can see the media, very high echoic media. That's meaning this vessel is shrinking because of the low flow. So now here is this is maybe the end of the almost CDO, right? So, but inside of the CTO, you can see the very big, original size is that 3 or 3.5.
Yeah.
So this is the second diagonal now. So you can see some small calcification, but almost fibrous plaque is there. And then this is the first diagonal.
First diagonal. Yeah.
So we needed the stent around here, but the discrepancy between the distal and the proximal LED is one of the issue of this kind of the case, right?
Yes.
So anyway, we need to the small balloon dilatation for the second and the first diagonal before stenting. So ニトロ入れる？ニトロとか。So
you
how do you
would
think about the stent size for this case?
It's almost a minimum of 3 millimeter and approximately dilate to 3.5 at least. What does the panelist think?
Well, in this kind of situation, in my practice, I repeatedly give some nitros to have the vessel to see whether the vessel grows intraoperatively. But in my experience, maybe 70 or 80% does not grow significantly intraoperatively. So there's a quite a size discrepancy in this kind of case, and there's no plug. I would like to land the stent at the negative remodeled vessel, but just overdilate about 15 or 20% very carefully.
Yeah.
And after that, I would just maybe depending on the final result, I would like to have a second look a few months later to see the stent opposition or the distal vessel status maybe.
Now looking at this angiogram, there's some haziness in the ostium of the first diagonal. So would you pre-dilate this before stenting? Or number two is, what is the diameter of the stent that you would choose to if you're going to use one stent? Dr. Chu? Yeah? What diameter stent would you choose to use for this LAD?
The distal diameter, according to the IBIS, was about 2.0, 2.12, right?
Yes, I think so.
Well,
would you use a 3 millimeter diameter stent? Because originally it looked like 3 almost.
Yeah, but
I'll probably choose a 3 millimeter stent because the diameter at the second diagonal branch was about 3.5 millimeter according to the IBIS. So probably I'll use a 3.0 stent.
And then proximally, before the diagonal, you may want to do a pot or something in the end and make it like 3.5.
Yes.
Now, this is interesting because the ostium of the first diagonal does look very hazy. So would Dr. Nasu pre-dilate this first diagonal?
Yeah, I'm wondering. I already dilated the second diagonal for sure.
Yeah, it's a smaller diagonal.
Anyway, I want to use the bottom protection for stenting for the diagonal, first diagonal. So maybe I don't need to dilate it before stenting. But I would, yeah, I'm wondering the size is maybe 3 or, but the length is 38 or 30 something, I guess.
Yeah.
どれぐらい ?38 でもういいかな。あ、そういうこと。いや、でもね、そっと広げれば大丈夫でしょ。うん、どういうかな。いやいや、むしろ、そう、長さ。38でいいか。うん。
Yeah, so after ballooning, the anatomy of the first diagonal seems unfavorable. Yeah, so at least I think I agree that we have to do something with that place. Maybe you can look at the ibis for the first diagonal and decide.
Do you want to see the ibis now for the diagonal first diagonal?
It's up to you. It's up to you.
Okay, yeah, it's okay. I can show you. So we have sometimes.
Yes.
So already wires can be closed. Okay, so ibis is here is in the first diagonal. So first diagonal is also very big. Maybe size is 2.5 something.
Yeah.
And then LED is coming from the 3 o'clock. So orifice has some disease. But fortunately, the plaque is located. Plaque distribution is the septal side, right? But anyway, I'm afraid it's side branch compromisation for stenting. So, okay?
Yeah. I see. So knowing that there may be some compromisation of the diagonal, first diagonal, after stenting, would you modify the plot first?
No, yeah, I'm just keeping the balloon.
I see. You're keeping the balloon inside. Yeah. I see. Yeah.
And after dilatation, I want to do the final kissing inflation.
So what's the balloon size you're keeping in the diagonal?
2 is enough.
Okay.
Is that going to be a brand new 2O balloon?
No, it's already, it's an old one, right?
Already used.
It's already used, yes. じゃあ、3の38でいい？いきますか。ちょっと長いかな。まあでもいいよね。So I selected the 3O38 stance, Onyx from Medotronic. Well, ちょうどいい感じだね。見ながら。ちょっと長かった。でもこんなもんだよね。はい、じゃあ待って。ちょっと待って。はい、じゃあ撮りましょう。まあいいんじゃないのね。はい、はい。いくよ。
Dr. Nasu,
yes.
When you do this technique, your side branch balloon, the proximal, end of the balloon should be more proximal than the stent balloon. Is that right?
I'm sorry?
The side branch balloon where you park to protect the diagonal,
Yeah.
proximal dot marker should be more proximally situated than the stent.
But
that correct?
yeah, I think it's okay.
It's okay.
So maybe yes.
Uh-huh.
Okay.
So would you dilate to nominal pressure first?
Yes. So the distal is very shrinking, so that
Yeah.
we dilated very slowly and gently.
Yeah.
So anyway, stent balloon is dilated.
This is interesting because you dilated both just to protect the diagonal, yeah?
いいかい。くさび用意して。シオンブルーだし、シオンか。シオン用意して。よいしょ。
I'm interesting to see an angiogram now. You know? After you stented it, I like to see how the diagonal looks like now.
Okay.
Before
I
dilate.
can show you.
Yes.
Before post dilation, do you do the angio after you do the balloon at the side branch like this?
You mean the angiogram now, right?
Yeah, maybe if the diagonal is compromised, then it's better to wire it first before post dilating.
Yeah, of course. Yeah, now I want to select the diagonal before post dilatation. It's okay.
Nice. Yeah.
So fortunately, second diagonal is also okay. So
Yeah. So when you dilate the stent, implant the stent, you also dilate the side branch balloon, and that's you usually do that, or like just like a kissing inflation.
Anyway, this is diagonal balloon is outside of the stents. So the main purpose is that I want to keep the diagonal flow. So that's why after stenting, we should select the diagonal branch before the final kissing inflation or the post dilatation. どうしたの?
Now the ostium of this diagonal looks significant.
Well, usually, do you want to implant the stent for the diagonal in this kind of situation?
I think most of the panelists in the beginning was thinking of a provisional stenting, a single stent. And then if necessary, dilate the side branch diagonal using a balloon, perhaps a kissing balloon technique.
Okay.
I'm very impressed with your technique of balloon protection outside the stent. So did you use the double lumen catheter?
Yes, of course.
To make sure that you're inside the stent, yeah?
Yes.
Well, that's a very good use of the double lumen. Wow.
So for this kind of the procedure, the DLC is quite useful.
Very useful.
Yeah, for safety procedure.
Yeah.
あ、ごめん、ちょっと。よいしょ。はい、どうぞ。ちょっと待ってね。じゃあ、アイバスする一応。So now I can show you IBUS. Maybe you can see some space outside of the stent, the proximal side of the CTO, because we dilated the tubal balloon during the stenting.
Yeah.
So I want to confirm the wire position and then decided the balloon size for final kissing inflation.
Yeah.
Okay. はい、いくよ。はい、記録して。Okay, okay, stentage is okay, maybe no dissection. Okay, plaque is beginning. So second diagonal is it's okay. So here is first diagonal stent is here. Wire here.
Yeah.
So we cannot clear space. We are not sure. Maybe the 12 o'clock is the space we can see. But anyway, the position is very bad, so we should dilate.
Correct. Yeah.
So どうしようかな。So which is first is better? Final kissing inflation or the pod?
Yeah.
Yeah, I'm not a specialist of the bifurcation. Could you tell me?
Dr. Nakamura, please advise. Can't hear.
3.5 とか入れちゃう ?4 でもいい
We can't hear Dr. Nakamura.
3.5 だね。もういい
Usually,
3.5
pot and cavity and pot. This is the usual way.
Okay, the final kissing inflation first, right?
Yeah, pot and cavity and
Pot and KBT.
pot cavity and pot. This is the usual way.
KBT followed by pot. Yeah.
Depend on the operators.
どうしよう。いや、俺もどっちでもいいんだけど。
Dr. Tsao, would you also do a kissing balloon followed by
でしょう
pot?
か、先にね。
Yes, this is what I usually do. Kissing first and then pot.
Uh-huh.
じゃあ、3ミリでいい ?3 ミリでいいよね。
But in this case, it looks like from the iris,
3.5 でかいな。
the segment of the stent where the second diagonal comes out, yeah, the original near the second diagonal also was under inflated.
2はちっちゃくない
Yes, yes.
So I guess the post
OK。じゃあ3と2.5ちょうだい。
that area.
They should post dilate the segment proximal to the second diagonal with bigger balloon.
Uh-huh, I see. What about putting a 3-or NC balloon and inflate it to very high pressure, like 18 or 20? Would that be sufficient, you think?
長さいくら
I thought from the iris
長
like
さ何本
2.5-ish.
20なんていらないいらない。ダメ。12とか短いバルーンにして。いや、さ、ピンポイントでもね、物も。
Dr. Hong, would you also
ピン
do
ポイントで
a
物持ってこないで。
kissing balloon first into the first diagonal? Would you bother doing a kissing balloon
2.5 の
into
バ
the
ルーンは
second diagonal?
I think in my practice, I would actually kiss the first diagonal and then subsequently pot proximally as big as you can.
Yeah. And you see the second diagonal wire is still outside the stent.
で、同じ長さのバルーン出してよ。あるでしょおってな。いけるセカンドダイアゴナル大丈夫かな
So what's the next plan now, Dr. Nasu?
This
NC.
is a 3.0 NC balloon.
Uh-huh.
So I will use a 3.0 and a 2.5 for the final kissing inflation.
Uh-huh.
And then maybe the final port dilatation by 3.5 or 3.75 or something, according to the IBAS findings.
Uh-huh.
Okay. Okay.
So would you use the TCP to treat the diagonal branch?
Sorry?
Would you use the drug eluting balloon to treat the diagonal branch?
Usually I don't use the DCB this kind of situation. Maybe diagonal is patency is very nice usually. Ankasho. 大丈夫。6。
So this is the 30 NC. Would you go up to what, 18 atmosphere or 20?
Okay, we can dilate. はい、18。
あ、
20。22。
What pressure did you go up to, Dr. Nasu?
22.
22.
But still, so that we can dilate the anchoring. よいしょ。あ、ダメだね。ちょっと待って。よいしょ。これなるよな。
Balloon cannot pass through the stem strut.
Okay, anchor it.
Okay, it passed.
よし。はい。左やるよ。はい。ロック。
Wow, that's the kiss.
6、8、10、10。
Still seeing something in the ostium of the diagonal.
12、12、12。
I guess there's no need to achieve 100%.
OK。もう一回。はい、もう一回。8、8。ゲビリ。8、8。OK、ダウン。よし。中ももうちょっと広げるか。ここな。中も広がってねえな。はい、どうぞ。14、16、18。はい、できました。リスターでもまあ広げてみ大丈夫な。はい、どうぞ。はい、12、14。はい、よいしょ。So without distal edge, I dilated by the 3O with high pressure. So now
Okay. So you're likely to finish with a pot. Would you keep the second diagonal wire in with the pot, or you take it out?
Yes, but in this case, is not the calcified, so the after final kissing relation, maybe wire removing is not so difficult, I guess. So, but anyway, we should check. じゃあもうポートしちゃおうか。じゃあ35か375でもいいんじゃないと35でもよかった。375でもよかった。ちょっと、おーい。これ。合います。3000出して。エッジ切り、プロキシマルのエッジギリギリ。プロキシマルだよ。プロキシマルのエッジだよ。まあ、3、4、OK、今回は、まあ、375でいいや。375ちょうだい。375短いバルーンだよ。短いの。いえ、長い。
Okay, just to let you know, Dr. Nasu, according to my time, is about 5 minutes.
So Nasu, how long do you use the DAPT for the CTO patients?
TA?
DAPT.
DAPT, it was 6 months or 12 months?
Yeah, according to the case, yes. Usually the 6 months.
6 months.
Yes.
Okay.
Does that 6 months depend on whether you're using the thin strut stent?
Mm-hmm. Okay. But the issue is the stenting length and the stenting size.
Uh-huh. This is the 3.5 NC?
3.75.
7.5.
14。これで大丈夫なはずだ。もうエッジまで来てるよね。エッジまで行ってたよな。で、これでじゃあ12ぐらいまで行こうか。あんまりやりすぎてまだサイドブランチか。はい、で、フレッシュ。はい。で、アイバスしよう。よっしゃ。So maybe we can show the final IBUS and the angio quickly,
Yes.
and then finish this session.
Uh-huh.
Oh, oh, hi. Yeah. はい、記録して。よし。
Very nice.
Maybe this but this base is still shrinking, but the edge of the stent is okay. So we already dilated the 3O with high pressure.
Yeah.
But this is second diagonal. First diagonal is maybe, well opened, I guess, yes. So issue is the edge of the proximal edge. Proximal edge is also maybe not so diseased. I think it's acceptable.
1, 2, 3.5. Yeah.
So let's check the angio.
Yeah.
ニトロ入れますか？じゃあ we put the nitro, nitro. Okay. しっかり充填してね。
We have, I think, 2 minutes, and then I think my my boss and my good friend Dr. Nakamura is going to summarize the case. Yeah. Is that correct?
Okay, it's okay.
Huh?
Maybe first and the second diagonal roll twice is acceptable, I think. So you can see some narrowing in a diagonal for sure, but this vessel is not so big, so we can leave it today.
Yeah.
So
it's going to grow in the future. Yeah. Wow, that's
an excellent result.
Excellent.
Yeah. Nasu sensei,
Hi.
do you want to say something more?
No?
If not, I summarize.
Yes, please.
Okay. So today, thank you very much, Dr. Nasu. He showed a very elegant technique in LDCTO, not so easy one. And actually, this kind of case, we should check the angiogram very carefully. And we need to select appropriate strategy, including guaranteed lateral approach. And then today he showed us like very sophisticated, very gentle guide wiring we need. And also he always show us we should check the two different orthogonal view, like eleocranian or true lateral. This is very important. And finally, after wire passing, we should set appropriate stenting. Maybe I think 50% of the CTO we have a bifurcation reason. So we should select the appropriate one. Today he showed a very elegant, just a single stenting and balloon protecting way. This is very educational. Anyway, thank you very much today. He showed a very elegant CTO technique. Thank you very much.
Thank you very much.
Thank you very much. I'd like to thank all the panelists, chairperson, Dr. Sunao Nakamura. Actually, I was informed Dr. Praveen Chandra did join us. I couldn't see his picture or video. Dr. Chandra, welcome, but thank you very much for joining us as well.
Thank you.
Dr. Nasu, thank you so much for a very elegant case, as Dr. Nakamura has mentioned. And I like this double lumen catheter demonstration very much. Okay. Thank you very much.
Thank you very much.
Thank you.
Thank you very much.
Thank you. Congratulations. Thank you.
Congratulations. Thank you.